in the physical therapy program at Maryville, and my research is on medical history and medication inventory as important parts of patient care, a case study. I worked on this with Dr. Sangosini, a physical therapy professor in my career, and basically this is a poster that her and I worked on together throughout the course of the semester. The background and purpose of our research is that medical history and medical reconciliation are significant components of patient-centered management across all settings of the physical therapy profession and practice. The purpose of this case report is to inform the reader of the importance of patient medical history and assessment and evaluation, leading up to designing an effective physical therapy plan of care. Understanding all these patient medications and pharmacokinetics involved with this, including possible side effects, also allows the physical therapy to develop a personal plan of care that is complementary to drug intervention. This also prevents complications in facilities to an optimal functional status for many patients. This case study also prevents a report on what happens when physical therapy outlook or omit to complete a medication inventory or check for a patient. The case description that we based the case study on is a 52-year-old middle-aged Caucasian female. She is status post-conformist bicompartmental knee replacement. Conformist knee replacement is a specialized form of knee replacement where the knee replacement is formatted to the patient's body and not a standard knee replacement that comes with the most common form of knee surgeries. This conformant implant, again, is a made-to-specific knee replacement with a 3D technology approach. This requires modification to usual standard total knee replacement protocol and management to optimize the certain benefits that aren't normally included with a specific knee replacement. Research findings suggest that this BKR implant has significant advantages over the conventional one, but it demands that it have communication between the disciplines, coordination, and collaborative management approaches, which must include the patient. This narrative provides an account of the patient's acute care, home health, and outpatient physical therapy experiences. Adding on to this patient and her more, I would say, abnormal knee replacement is that she had significant past medical histories that were not involved in a typical patient coming in with a knee replacement. A typical knee replacement patient can be anywhere from probably, I would say, 30s to upper into the 60s, where insurance is giving that knee replacement option. But this patient specifically has a past medical history of Crohn's disease, lupus, and Sjogren's disease. All three of those are autoimmunes that will attack the body and cause significant complications in surgeries. She also has hypertension, osteoarthritis, adrenal insufficiency, IgG deficiency, scleritis, neuropathy, and neutropenia, and a BMI of 26.6 kilogram per meter squared. The medication history is that she was also taking prednisone, Flexeril, Biastolic, Dexilant, Benlysta infusion, and oxycodone is needed for the pain at the time of the knee replacement. Basically, the status of her management post-surgical is that she went through several lines of physical therapy. With the acute care is when she was at first in the hospital. And so immediately after surgery and knee replacement, they try and get the patient flexing and moving their knee as soon as possible, unlike some other surgeries where they have the patient rest for and are immobilized for a number of days. This is one of the rare therapies and surgeries that require the patient to get up and moving as soon as possible. She was in the hospital for 5 days of inpatient physical therapy, and the discharge status of that was that she was walking with a walker with moderate assistance. She's able to actively bend the knee to about 75 degrees. In her case, that was noted in the notes from the physical therapist, was that most knee patients aren't normally able to flex their knee as much, but they're able to get extension easier. In her case, her extension was the hardest part, and she was able to flex more than normal. She was then moved to home health care, which is a physical therapist coming into the home and directly working with the patient without having them to travel anywhere for physical therapy. This was 8 visits for 2 weeks but unfortunately because of insurance and other complications, she was only received 4 visits. The discharge status from this home health was that she was able to walk with a cane and drive a car, and she was actively able to bend the knee to about 90 degrees. So there was an improvement from acute care to home health. Outpatient care is where this case study is mainly focused. This patient received physical therapy for 18 visits for 6 weeks. Because of treatment, she was able to attend only 12 out of the 18 visits prescribed. The issues occurred mostly here. Therapist insisted that patient had to take medication before session, and patient was unable to because she had to drive herself to visit. This was a repeated thing that the therapist was made to tell the patient, and the patient felt that she was not receiving an adequate quality of care because of the medication wanting to be required by the physical therapist. And because of that, she self-discharged herself due to the lack of progress in knee motion. She would then return to home health care with the surgeon prescribing her 2 Dyna splints. Basically, these are splints able to provide flexion and extension with the patient providing the level of strain on themselves, one straight and one bent to facilitate movement for the next 2 weeks. The discharge status from these Dyna splints were they were able to full range of motion after 6 weeks. Again, the outcomes in outpatient care is that medical history, medication, reconciliation were not fully integrated into the plan of care by the outpatient physical therapy staff. And the patient overall was displeased with the quality of care because of the apparent lack of consideration shown by the staff about her condition, the medication interaction with the function, and the overall movement and pain level. Because the staff was not proactive in the approach about understanding the medication, how much that interacted with the patient and her protocols, this led to a breakdown of patient and therapist relationship, which led to a patient leaving before the prescription ended, which is not the goal in any of this case. What we wanted to end on is that medication inventory is an important center for medication and Medicaid service qualities indicator. Best practice in physical therapy to prevent adverse medication effects includes performing a standardized medication reconciliation process, and overall communication with the patient to understand their goals and involvement of other care providers across the patient care continuum is so huge and so important that it can lead to a breakdown in relationship and not have a patient succeed to their full needs and their goals that they're wanting to achieve. If there is not enough background done on each patient before a visit, or if that background is not carried over from evaluation into active exercises, then that patient feels that they are not being listened to and that they are not receiving the quality of care that they need regarding their own individual care. Physical therapy has a very wide share of exercises that is shared between patient to patient, but those exercises have to be individualized to each patient in order for that patient to feel like they are receiving the best quality of care because of their background, their medications that they're currently taking, and their past medical history. A therapist should also never require a patient to take medication before the session, especially with self-extenuating circumstances like driving themselves to their own visit. And a patient should not receive less quality of care because of this factor. A therapist should work around these barriers and these decisions that they have to focus on. Overall, a therapist has to rely on the medical history and medication inventory. That's why one of the first things that should be asked is your medical history and what medications you're currently on or have taken. This can lead to issues with manual therapies, as in a patient on blood thinners bleeding more, patient with hypertension having more swelling. It's a huge part of the therapy process that is starting to get, I believe in this case especially, was overlooked, and that could have affected the patient for worse. Thankfully, this patient was able to make a full recovery, but I feel like if this patient was not proactive and did not have an advocate as her own self and a doctor that listened to the patient and not the therapist, then I'm afraid this patient may have had a worse turnout than this. Overall, medication inventory and medical history are a huge important part of patient-centered care, especially in a highly individualized field such as physical therapy. Thank you, guys.
Thank you very much, Cierra. If anybody has questions, feel free to ask. Otherwise, I don't know if you can see the chat, Cierra, and see if any questions.
Let me try and get back to Zoom really quick.
I can feed them to you if that's helpful.
Yeah, that would be great.
So the first question is, what kind of medication would a patient be asked to take right before a physical therapy session?
Typically, this is a pain medication. So in this patient's case, it was the oxycodone 5 milligram. This typically allows the therapist to work more with the patient, but can lead to, in this case, this is what the therapist was asking, to basically have the patient have medication that would allow them to work further and not have the patient in as much pain when working with them. This sometimes happens. Really, the only thing a therapist should be prescribing is I would recommend a Tylenol, or I would recommend a Motrin after a therapy visit to reduce soreness or swelling. I can see the chat now, so all right, Rebecca, how did you decide to study this topic? I've been in physical therapy. Most physical therapy majors will tell you I have been in physical therapy for most of my life. And I would hear stories from other patients when I was a patient myself about just kind of horror stories like of this same thing. So when I got into Maryville and I started talking with Dr. Sangosini, and we just started talking about this topic, we ended up finding a patient that had one very similar, and we ended up doing a case study on that patient to relate to a wider branch of the field that happens, unfortunately, a lot. Dr. Ulrich. I would say for your first question, Dr. Ulrich, it's a little bit of both. If we typically in a packet that a physical therapist gives to a patient pre-evaluation, there should be a whole page with medical record and medication list. If in the initial evaluation, it should be asked again to confirm what medications you're on, or if a patient is older and says, I have no idea, then you might reach out to their doctor and say, could you please provide me a medication list or any medications you prescribed from that doctor. And medical history, again, it kind of depends on the patient and how old they are. Typically, it should be provided out on the initial evaluation sheet, but they may reach out to the doctor or the surgeon and say, can you please give me their medical history or any past records you have on them. With communication between physical therapists, MDs, there should be communication. It definitely depends on the doctor and the physical therapist. Some doctors do not see physical therapists on the same level as them, unfortunately. So there sometimes is a breakdown because they don't believe that that they are on the same level, so they don't deserve the same quality of information, which again, that's an issue that is being brought into the field and thankfully is being broken down year by year as we become more stricter in the topic of direct access and providing people easier access to getting to physical therapy. Doctors are very important to the role of physical therapy, but sometimes they come in too late. Normally we just request scripts and referrals and things like that from them, but we have to reach out when a patient is having difficulty or when a patient expresses distress and says, can you please talk to my doctor, or the other way around, and the doctor says, I need to talk to the therapist in regards to this patient because this patient doesn't feel comfortable talking to the therapist, but they feel talking to me. So I would say they have a good relationship in terms of getting patients, but in regards to the quality of care between patients, there needs to be a greater line of communication that I don't think currently exists right now. And that's it.
Well, thank you very much, Cierra. It's an excellent poster and we appreciate you sharing it with us.
No problem. Thank you guys. I appreciate it.
So our next talk starts at 10:20. So we'll just take a couple minutes and we'll get our next presenters going a couple minutes before 10:20, say 10:18.